Until the early 2010s, the chemoimmunotherapy-based regimens were really the gold standard for all patients with CLL receiving initial therapy, including those patients with high-risk markers such as deletion 17p. The major innovation over the last several years has been the development of novel agents which target a variety of different pathways in the CLL cells that work very differently from chemoimmunotherapy. One of the biggest insights in this disease was that targeting the B-cell receptor pathway can be a very effective strategy. This is a key survival pathway for CLL cells in the lymph nodes and in the bone marrow. And by disrupting this pathway, these new drugs can actually move CLL cells out of these protected microenvironments and into the bloodstream, where they become more susceptible to dying through a process called apoptosis. So examples of drugs like this include ibrutinib, which targets Bruton's tyrosine kinase in the B-cell receptor pathway, and idelalisib, which targets PI3 kinase, the delta isoform, in that same pathway. Another strategy has been to target the apoptotic machinery of the cell directly, and that's the drug venetoclax, which targets a protein called BCL2, which is a pro-survival protein that's really one of the key regulators of apoptosis or programmed cell death. And venetoclax is also a very highly effective agent that right now is only approved for patients with relapsed CLL who have this high-risk 17p marker, but increasingly is being worked into different regimens as a combination approach. The FISH testing has been around for quite a while now. The original papers came out around 20 years or so ago and defined these different subgroups of patients who are at different risks for progression and ultimately for poor survival. One of the older techniques to look at the chromosomes of the cells was actually a karyotype technique, which was not very fruitful in the early days of CLL because we couldn't identify a lot of the key abnormalities that we need to look for. In more recent years, there's been new techniques to look at karyotype, for example, by a CpG stimulation technique that can bring out some of these abnormalities that we weren't seeing before. And so one of the things that's evolved in the last few years is looking at the complex karyotype, which involves 3 or more different abnormalities in the chromosomes of the CLL cell. And we know now that those patients who have the complex karyotype, particularly those who have deletion 17p as one of those abnormalities, have a particularly poor prognosis, unfortunately, not just to the chemoimmunotherapy, but even to the newer drugs when they're used as monotherapies. So I think that complex karyotype is one of the key innovations that's been discovered over the last few years. I think the FISH remains a very important test to define this deletion 17p. And then the other thing that we should be testing for is the mutational status of TP53. This is the key regulator gene that's on chromosome 17, so it can either be deleted, as in deletion 17p, or it can be mutated, where the chromosome is still present. So we don't see that deletion on the FISH test, but we can detect a mutation in about 5 to 10% of patients at the time of diagnosis. And this does confer resistance to therapy and increasingly has informed our choice of therapy because we've moved more toward a novel agent-based approach and away from chemoimmunotherapy for those patients. In terms of other chromosomal abnormalities that we see in CLL, another common one is deletion 11q, which we think deletes ATM. That's the main gene on 11 that we think is responsible for some of the pathophysiology of that abnormality. This is seen in about 20% of CLL patients at time of diagnosis and tends to be associated with bulky internal lymphadenopathy, a need for treatment sooner in the course of the disease, and a less durable response to chemoimmunotherapy-based regimens. We have some conflicting data about this abnormality in terms of the response to the novel agents. Originally, from some of the ibrutinib studies that were first performed, there was a suggestion that the durability of ibrutinib therapy was less for patients with deletion 11q. But some recent data actually suggest in a larger data set that that might not be the case and that patients with 11q deletion can actually have very durable responses to ibrutinib-based therapy.
The transformation of CLL to a more aggressive lymphoma is a rare but feared complication or development of this disease. Many patients will ask about that even when they've first been diagnosed. Unfortunately, it is a rare event occurring in between 5 and 10% of patients. At this point, I do not think there's still a large amount of understanding of what factors can predict Richter's transformation or transformation to a large cell lymphoma. Some studies have looked at germline mutations in genes like BCL2 or CD38. Some studies have found an association between deletion 17p, between unmutated immunoglobulin genes, and also with Notch1 mutations. But it should be emphasized that there are many patients with those same factors that do not transform, and so I do not think any one of those or even multiple risk factors destine any one patient for transformation. There has been a lot of good work done to examine samples from patients that have had transformed disease, and I think there's better understanding of the genetic changes that occur It appears that mutations in p53, c-MYC, or loss of CDKN2 account for about half of the cases. Notch1 mutations account for about a quarter, and then the final quarter are kind of a heterogeneous mix of mutations. But hopefully with that information, we could get better at treating these patients and improve their outcomes too.